Let's talk about inhalation injuries. Now, an inhalation injury is described as the damage to the lungs by the inspiration of superheated gases. These are usually temperatures greater than 150 degrees Celsius. Steam or noxious products of incomplete combustion. This can include carbon monoxide or other toxic gases. It is the most common cause of death in burn injuries. Now, inhalation injuries are divided into phases, and it's based upon the varying pathology and the treatment requirements. The phases are exudative, degenerative, proliferative, and reparative. Soot is actually particles of ash that get deposited into the airway. Smoke and gas can actually travel farther than soot, but soot alone is accounts for 10% of the cause of death in most inhalation injuries. Take soot, smoke, and skin burns together, and the cause of death goes up to 30 to 90% with those three things together. Now, smoke inhalation is the most common form of inhalation injury. However, I did speak in Respiratory 100 about chemicals when we were talking about cleaning and sterilization, and acid-base. And during the acid-base lecture, I talked about mixing acids and bases. Things like Comet and bleach, creating chlorine gas. That would be considered an inhalation injury. If you have an inhalation injury and you develop pneumonia, it increases your mortality by 60%. So we're just compounding the problems. Let's take a look at a few pictures. So this is a bronchoscopic image of the trachea and the carina after airway inhalation injury. And you can see all of these little white blisters. Okay, this looks just like a first-degree burn. There's one over here, and you can see them on the trachea, down in here. Also note that the trachea is rather red and inflamed. This is a bronchoscopic view from chlorine inhalation. So I was just talking about, chlorine gas inhalation. And you see these white marks here that are marked with the arrows. You see some that aren't marked with the arrows, but they're the same thing. And this is the damaged mucosa in the right middle lobe of this person's lung. And those areas are basically dead tissue. And it will slough off. Here is what soot and ash deposits look like after an inhalation injury. So this person will have a lot of trouble with the death of the cell walls, death of cilia, trying to clear this out of the airway. And we need to keep those areas hydrated. The soot can dry out. We call it desiccate. And once it does that, it can then create a blockage in the airways. So we need to keep it moist and mobile. So let's take a moment to stop and think about something. You're the respiratory therapist covering the emergency department. You get a call, patient is coming in, sustained a flash flame injury to the face and upper torso while working on their car. When the patient arrives, you hear stridor and note that his mustache and nasal hairs are singed. What would you consider next to manage the patient? First of all, I want you to be aware that this is the type of question that the NBRC will ask you on your boards. And when they talk about burn patients for inhalation injury, they are going to say about the nasal hairs being singed or the mustache being singed. This is a telltale sign that the patient probably has some type of inhalation injury from a fire. So you need to consider that right off the bat. So what would you do to manage this patient? Well, the first thing is the patient is going to probably need oxygen. And they're also going to need humidity. Because again, we want to keep things moist, we want to keep things cool, but we need to put oxygen on this patient. Keep in mind that an inhalation injury involves the entire respiratory system, not just the upper airway, not just the lower airway. And that gases from the fire can dissolve into the mucus layers of the upper airway. Please be aware that things that are burning in the fire can create gases. So it's not just smoke. There may be plastic burning, there may be household chemicals burning, the stuffing in the couch, the stuffing in the mattress, anything like that. Those types of chemicals will be released and can be absorbed into the patient's bloodstream through the mucosa of the upper airway. And these gases and other particles are going to form concentration gradients throughout the upper and lower airways, meaning depending on the size of the particle or the lightness of the gas, they will deposit in different areas within the lung or the airway. So larger particles and heavier gases are going to settle lower in the airway, where smaller particles may get even deeper into the airway, and some lighter gases may just affect or be absorbed through the upper airway. Now, the morbidity of severe burns increases when accompanied by smoke. Inhalation due to the stimulation of the inflammatory response and loss of small airway patency is the biggest problem. So basically your patient is going to end up with bronchospasms, and the airways are going to start to collapse from the bronchospasm and the irritation. Diagnosing inhalation injury is usually difficult because there's no uniform criteria out there, and there's absence of generally accepted and applied methods for quantifying inhalation injury. Nobody can agree what an actual inhalation injury is or how severe it is. The NBRC looks at if the nose hairs are singed, if there is soot and such to the face, burns to the face, you are to consider that your patient has an inhalation injury. So when the patient comes in, you're going to, of course, be assessing your patient. You want a history. Now, when we talk about history here, we're not talking about a typical patient history. We're going to be talking about the history of the fire. What type of fire was it? Was it a house fire? Was it a car fire? What? And of course, you're immediately going to be examining your patient right off the bat while you're getting this history. Remember, singed nose hair. That's one of the things you're going to be looking for. You're also going to be looking for burns around the neck, on the chest, on the back. We also want to get a chest x-ray as soon as possible. This can also start to show us if there's some air trapping or inflammation starting to go on. You're not going to see soot or anything like that on the x-ray, but it gives us a baseline. We may need to, once the patient is stable, do a bronchoscopy. So we go down into the airway and we are physically examining the airway to see what does it look like, how far down do we see this kind of damage. We also do PF ratio. That's the arterial oxygen divided by the FiO2 that the patient is receiving. As you learned earlier, this is a great tool to use when we are looking for ARDS. These patients are going to potentially develop ARDS, so we want to keep an eye on the PF ratio. And we also need to look at radioisotope scanning. This can help to tell us if there's certain types of things in the patient's lungs, wood ash, that type of thing, that we may need to know about in order to take care of. In the next video, we're going to talk about treating inhalation injury.